So if you have a question, please feel free to come up to the microphone and please tell us your name and where you're from.
Yeah, we purposely actually left like 20 minutes
Let's
for
take the
this
time.
because we actually wanted to make this more of a conversation with our community because we don't really get a chance to do this.
Hi.
Hi.
I'm Eve Harris, and I'm a survivor. I don't use the word. I'm 9 years Ned.
Wow, congratulations.
Okay, thanks.
Thank you for coming to talk to us here.
You're welcome. I was an advocate before I was diagnosed. In fact, I was working in communications at UCSF when I was diagnosed. Took some time off, became more involved in advocacy, studied to be a navigator, and lo and behold, I'm hired back at UCSF to navigate newly diagnosed patients. So, and in my spare time, I do a little patient engagement coaching, and I wanted to well, thank you all for doing what you're doing. Is the whole room oncologists, and are there no other patients?
Are there any other patients or patient advocates? Oh,
There are.
They're a handful.
Yes.
Yeah.
Because, you know, it kind of seems like duh to us, but we really do appreciate you raising the level of conversation with one another. I encourage patients to talk back, to do their own talk back, because I'm thrilled that medical education is including that now, but I'm encouraging teach back to patients. So let me see if I got this straight. Can I summarize that for you? You know, can you give me a timeout so I can tell you what I think you said? Or here's what I'm going to do when I leave this appointment. Is that what you wanted me to do?
Yes. No, it's a terrific idea. And I know there are other intervention studies going on but, now that coach actually both the doctor and the patient. So I clearly think there's a really important role for patients having a sense of how to get the best out of their appointment and the best out of their clinicians.
Yeah. The only thing I would actually say is I actually think you raise a very good point. Some of the things that I've experienced, and I'm sure I'm not alone here, is I don't want people telling me how to talk to patients. And I certainly don't want folks in my institution telling patients how to talk to me. So it's really vital that this happen in the sense of a coordinated interdisciplinary manner where you will know what your advocates are telling the patients that come in to see you and you buy into that because what they're doing is important. But this whole empowerment of patients, the reason that we're here is because we think, and we think that oncology is going to be really well served if we do, as we're doing all across oncology, and we're dealing with government and insurance and everyone else, we should be leading or at least partnering with our patients and our advocates to make this happen.
Yeah, it's an interesting conversation in the shared decision-making community about whether you train doctors or whether you try to have a patient revolution in terms of, you know, patients going and demanding that this is what we need to be doing in medicine. But I found, my background is actually not as an oncologist, a health psychologist. So I found when I've worked with patients, and you talk about it, patients sometimes feel like, well, now you're giving me yet another thing to do. And now I have to remember how to ask what I want to say. When I'm dealing with all this emotion, I don't even know how to communicate and stop when when my oncologist is going on this whole script that they've just started. So I've worked more with physicians because I think it's easier to stop the conversation a bit when it's starting from one place. But I think that patients can have a role in how to do this teach back or ask the right questions. I just personally feel like I don't want to burden patients with yet another thing they have to do in the system, even though it can be really great for them to be involved. And I think doctors can help them through that process in a way. So I think it's definitely a two-way street. I just think there's...
Yeah, I think it's going to take both.
Yeah,
definitely.
Physicians are a captive audience when they're in school, so let's train them right. Mm-hmm. Patient navigators can help, and
Yeah.
I'm also trained to be a third party during a consult, to be a note taker, to help elicit the important questions based on a patient's values. So yeah, I always encourage patients to bring someone with them who can take notes and not just write 30% for the remainder of the appointment.
Right.
Well, thank you for that. Let's go in the back.
I think it's just very difficult to accept as a doctor that our patients are more prepared to receive bad news than us to give bad news. And I don't know how we can change that concept because more of the time we offer false hope and we lie our patients, and the expectations that we give our patients are different than the expectations that the patient have at the beginning. And of course, when the patient go to internet, confirm that we lie. Then what's your counsel about how to give the patients, how to change our mind in terms that give the truth is the best way?
Well, when I trained at Memorial, one of my mentors, I still remember, it was my first week with him, and his first comment to me was, if your patient's not crying when she leaves your office the first time, you didn't do a good job. And I was like, that's horrible, But then I would see him in his visits, and none of his patients cried, because it was always hope, and it was always a positive message, and at the end of the day, it was positive. But I think you're right. I think I've learned that patients, when they're coming to see an oncologist, they're expecting to hear they're going to die. So I actually, if I see a look in their eyes, and after so many years of experience, and that's probably one thing we can take into training, you can see a look. You can actually see a cue where they're thinking about it. And if I see that cue, first thing out of my mouth is always, you're here because you have a cancer, and you are not dying. And if I thought you were dying, I'd tell you. In fact, if I think you're going to die, you'll hear it from me. And then I go on, and it's like the shoulders drop. But if you approach it head on first, because if you're thinking it and you think she's thinking it, and you're not going to talk about it, then there's already that barrier. Yeah. So my approach is always, and I think anybody who's been in with me, is I basically I call a spade a spade.
Well, I would just add to that I think that because we know that bad news is accompanied by a lot of emotion, I think our job is to figure out, how do you respond to the emotion, let it be okay, figure out how to deal with it in the moment, rather than try and prepare people not to be emotional, which I think is not something where we're going to make a lot of headway. I think it's our job to be in the moment with them. It's not our job to figure out how they shouldn't have all these emotions. I mean, emotions are actually a way that our beings process what's important. Yeah. Emotion is a way of thinking. It's not like some kind of add-on. So.
Right. What's so interesting, and then I'd love to hear your question, but it's so interesting about, just addressing the death from time zero. When you walk through a patient who you've had and you've taken care of for years, and they're getting to that point, emotionally it saved me, because I can then walk into someone's room and say, you know what, it's time. And they know exactly what I'm talking about. And then I'll go on and explain, but for me, emotionally, having, walked through that process and had that first thing that just slapped them in the face and said, you're not dying, and if I said, you're going to die, I tell you, they remember that going forward, and it's been really interesting. But for me, it's been an incredibly good way to deal with the stress of having to navigate poor prognosis.
My name's Amy McKenzie. I'm from Thomas Jefferson University in Philadelphia. I'm finishing my oncology fellowship. I'm going to do a geriatrics fellowship. And, we interact tremendously with the patients and the families. And we do that with all of our patients. And that's the question I have, and I apologize if this has been addressed because I came in late, but the thing I struggle with is when talking about end-of-life planning or sort of the next steps, and you want to align with the patient, you want to align with the family, and you want them to align, and that often doesn't happen, where you're saying, we've come to the point where we should be talking about what you want, what are your goals, and the family member sitting next to the patient shaking their head, behind them going, no, and you don't want to alienate the family member. My feeling is my duty is to the patient, but at the same time, it's hard. That feels very uncomfortable when the family member, out of love, feels maybe they need to protect the patient. But you also want to make sure that you're having this open discussion and that everybody understands. And I try to do sort of the hope worry. I hope, but I worry. But I guess that is the thing that I have not felt I've gotten any better at through fellowship. Maybe a little bit, but I feel like addressing a patient when the family is sort of, they're protecting the patient, and you want to walk together instead of be opposing.
Yes.
Some of this, I think, is helpful to plan. If you know when you're going to be discussing that, and it doesn't happen, you're seeing the patient pretty frequently by that point. So if you can prepare them for the visit a little bit, because some of the tension may come when they're not expecting to have that conversation, and then the family members have opinions they may not have shared with the patient, and the patient hasn't necessarily shared it with the family. Because people don't want to talk about it, it's uncomfortable, and so a lot of times family members feel their role is supportive, and they need to be the cheerleaders and I don't want to talk about what happens at the end of life, but and not realizing the patient has these beliefs and these feelings and preferences. So if you can prepare them in some way and not necessarily be the first person to address this right then in the room, then they may have some more uniform discussion, and you don't have to play the role of mediator as much, and you can more talk about from your perspective what you think is happening.
So I have two suggestions for you. One is when you realize during your visit that the family member may have different views, stop and say, you know, I'd like everybody to have a little bit of their own airtime. Give everybody their own airtime and say, and even if the family member says, well, the patient has the final decision, it's obviously their decision, you can say, well, you know, but even if it's their decision, you know, let's just hear your own thoughts about it. So make sure everyone gets their own little piece of airtime and, you know, feel like you have a moment to interact with each other, all of them individually, not expect them to agree. Because you know what? Most of the time they won't. So that's good. And really you're thinking about, as I've thought about this, it's really like my job to guide the social network towards the right decision. So that's one thing. So give everybody their own airtime. The second thing is when you say, I hope, but I worry, try changing that to I hope and I worry. Okay? Try those two things.
Thank you. Thank you very much.
Thank you. In the back.
Yes, Monica Logan, I'm a neuro-oncologist at MD Anderson, and in my view, actually, as a physician, the key is to start talking about this and applying all the strategies that you've talked about very early on. So that's what I encourage all the physicians to do. I'm taking care of brain tumor patients. We don't have a lot of time. So glioblastoma is a deadly disease.
Yeah.
So please start to apply all these strategies, not the very first visit, but very early on.
Yes.
And I think we'll build trust, and it's going to be much easier for our patients.
Thank you. Thank
Yes,
you.
and I would just say that even when you do this early on, it's still this discombobulating thing when you get to these big things. So I don't think it's not working if people are still upset, right? I mean, it still builds trust, but people are still upset.
Yeah.
And people are still upset. Thank you. Next.
Next in the back.
So you focus mostly on the interaction in the moment, the verbal interaction in the meeting. Two things. First, can you talk a little bit about written communications and how that might help? And also whether there's any written validated things we can give to patients in advance saying, this is what you might expect when you meet your oncologist. These are some of the questions you might ask. And then secondly, you've taken a lot of the burden on yourself. You take it on, you let the patient's shoulders go down. What do you do to protect yourself? You are the shaman. You're the shamans now. How do you keep from, like, you know, going home kicking puppies?
All right, why don't we do the first part of your question, and Dr. Politi will answer that.
You could do the second. There are a lot of evidence-based websites where, and also evidence-based decision aids. So if you didn't catch the links, I think they should be, the slides are published. So, but I can also email them to people. And there are some available. When they're not necessarily available for your specific context, if it's more a narrow topic area, there are some more generic, open-ended ones that at least structure the conversation in a certain way, and then you can fill in the information that's relevant, and or refer to websites that or paper-based information if people don't have internet, but that's growing, because that can help. So don't feel like you have to go through all of this in one visit. It's a lot of information to go through. It's really a process. You have the advantage in oncology of seeing patients more times and more frequently, so you can have this over a few visits and give them information in between, and that can be helpful. So what Tony was saying is bringing the quality of the conversation in the visit to a different level, so you can spend less time going through some of the details that they can learn on their own and more time answering these tough questions that you may have expertise to answer.
Can I also mention, I use Tom Smith's thing it's an old issue of JCO, but the article is called Tell It Like It Is, and he has a one-page outline that you can write a few bullets on basically while you're talking, and actually I do that with new patients, and it's very skeletal, but it gives them the framework of what you think the main points are, so I think very helpful for them.
So for the second part of that question, I learned, I also wrote about this on ASCO Connection, but I learned a very hard way how important it is to protect yourself. And I had great mentors at Memorial, but you know, as the new kid on the block, and I think everyone who's a new oncologist, the one who's in fellows training, be prepared. You will get every 30-year-old with ovarian cancer new to your clinic will come to you as a new provider. You will get the young mother with breast cancer who is still, still breastfeeding. You are going to seem like you're getting every poor prognostic patient, and you're going to see them all die together, all at the same time. And I went to every single funeral my first year, and I almost had a nervous breakdown, to the point where my mentor pulled me out of clinic for 3 months. At Memorial, that's pretty. You don't think Memorial or MD Anderson or MGH is going to do that, but there are some really great people embedded in all those institutions. So I put limits on my sensitivities. I don't go to funerals anymore. I say goodbye when I think I won't see somebody again, and then that's it. I say goodbye. I say, it was amazing to be a part of your family, to get to know everybody. I'm sorry it's come to this, and I will miss you. And then that's really helped me sort of persevere. It's still hard. But the other thing that I've done, and this is a big plug for ASCO Connection, there's a power to putting things in print. And I've enjoyed connecting with people in the community, but outside of the community, patients and just the public. And it's a way to, for me, it's been an affirmation that my experience is not solitary. And whatever that outlet is for each of us, we should have that outlet, because, we deserve a life. Oncology is difficult, but we deserve a life. Tony?
Can I just mention, I think that self-care issue is really critical. And the way I would put it is that I actually think self-care is also a kind of capacity that you develop. And so I feel like the things I've learned over the years are about how to keep myself in tune and how to keep myself tuned up. And actually there are things that you can do. I mean, there's a little bit of empiric study about, the other parts of your life that are important. I would point you to the work of Tate Shanafeld, who did the burnout study that was at the poster session. And then I think there's some other interesting sort of neuroscientific research about empathic capacity that I think is going to change. That I think is going to really help us in the next few years. Yeah. Thank you for that question.
Just say one other thing about it from a slightly different angle, where I think we're often shying away from addressing emotion because it's hard. No one wants to hear when things are really difficult and sad. But I would encourage you to think about how resilient people can be also, even in the end of life. And that has helped me a lot working with cancer patients who may be facing these difficult situations, that although they may have 2 months or 1 month or however much time they have, you can really help change their life at the end of their life, and help them live in the way that they value, the way that may be more meaningful than the past 10 years, because they've been dealt this difficult situation. And that doesn't happen for everyone, but it can happen. And if you can help them address that and work through it, people are much more resilient than we like to give them credit for, because we're often protecting ourselves by not delving into the emotion in the session, and because it's hard to do, and you're doing it all day, and you're doing it with lots of different people. But if you can think about how it can have this positive spin in times, then you may also feel a little bit better about it from your own perspective. So,
we probably have time for 2 more questions. In the back.
Yes. Firstly, thank you for a fascinating session. I'm interested in the topic of preparing patients for perhaps their initial consultation and the various tools that might be available. But specifically, has there been good research on the impact of pre-consultation educational material on the efficacy and satisfaction from that consultation? I mean, obviously there are things we can do to prepare patients. How much do we know about the impact of such preparation, both on the cognitive retention and the emotional satisfaction?
Yeah, it's a great question. I mean, you know what? The data is a little limited. The thing that I think comes the closest, I'm just guessing from your accent, you might be from a different part of the English-speaking world.
Well, yes, we do speak English in Australia.
And actually, the research I'm thinking about is the Australians. It's the work about question prompt sheets from Martin Tattersall's group and Phyllis Buto's group. And I think what that research shows is that equipping patients with some of the most common questions leads to them asking more questions in the consultation. In general, I mean, physicians can, it turns out, extinguish that behavior is their word. But I don't know if that has clearly led to longer-term psychosocial impact. There may be somebody in the audience who knows, but it's still not clear to me exactly what the more long-term outcome is, which is what I hear you asking for. And so I'm not sure if I have something that I can tell you that you should start doing that's validated with long-term impact right now.
That's interesting, though. I mean, it's a great question if we can improve the quality of care with a pre-knowledge of what the visit might look like. Thank you. Did you have a question in the front?
Well, yes, and I'd like to make a comment, too. I'm Charles Bailey, but I'm a patient advocate, and also I happen to be a doctor. But anyway, I just want to say I'm very impressed with you guys, and that you would put on this type of presentation at this conference, I think, is really appropriate. And you had a great turnout, too. I'm very impressed with the turnout. But this is really valuable stuff. You guys did a great job.
Thank you.
And, I'll chat with you perhaps later about a couple other things.
Okay. And to conclude,
Take up all the time.
Thank you so much, really.
Hi, I'm Craig Lustig. I'm a long-term brain tumor survivor, a patient advocate, and I've worked both with brain tumor patients as well as in the pediatric cancer community. And I think, and maybe it sort of doesn't need to be said, but it wasn't part of this presentation, that I think communication is a continuum. And I think it's really important to keep the door open and constantly give the patient the opportunity at every visit. Do you have questions? Are there concerns? Do you have things to talk about? It's not just a one-time interaction. I think that patients, especially patients who go through months or years of treatment, will have different levels of education as they move along and have different kinds of questions and become concerned about different things at different times. So I think it's got to be about a continuum. The other comment I wanted to make is that I do have real concerns about this notion of having, let's say, end-of-life discussions with family members at that initial point with family members in the room. I think it's really important, and because I'm sensitive to this since I was diagnosed in my 20s, that the clinicians that I had that I really valued their communication was when I went to the appointment, if one or both of my parents were there, they would say, "Mom, you stay outside for a couple of minutes. I'm going to go into the room. The two of us will have a conversation." And I think protecting the patient in that way is really, really important. If it's an older patient, I still think it's the same thing. And I think allowing the individual to have their time just with you, with nobody else, so that they can begin to process this. And then whatever else happens, whatever other people say, they can say. But it's important to have that confidential conversation first.
Yes,
Thank you.
A great counterpoint. Tthank you for mentioning that. Yes, in the back.
So Fran Boyle from Sydney.
Fran, how are you?
Good. Just to follow on from the question about Phyllis's research, what they found was that question prompt lists increased the number of questions that patients asked about prognosis, and that was the thing that changed the most. Just putting on the question prompt list, what is my prognosis? What will happen if the treatment you choose first doesn't work? That actually made a very big difference, and it actually reduced anxiety for patients and shortened consultation times. So I think what we worry about is that handing over power to the patient and this endless list of questions is going to just blow our day apart, but instead it means that people get the information they want. You don't go into a lengthy spiel that they don't care about, and you've actually had an easier day. So making a question prompt sheet for your own practice, for the conditions that you say frequently, getting your secretary to email it out to patients when they book their appointment, that might actually make your day a little bit easier.
All right, I think we're going to have to end here, but just before we do, there's some incredible voices in this audience, all of you included, but I see Terry Galuski's in the back and Michael Fish is in the back. There's some really great people here. So we're around. I think the presentation was recorded, and you should be able to access it that way if you want to share it. Please let ASCO know that you guys appreciate it if you did. And thank you so much for coming and staying so late. Thank you.